Welcome to the neurosurgical session here at the Head Injury Conference. I'd firstly like to introduce myself. My name's Chris Barrett. I'm a consultant neurosurgeon based at the Institute of Neurological Sciences here in Glasgow, and it's both a great honour and a privilege to be asked to host this session. Firstly, I'd just like to thank everyone else involved in organising it: Digby Brown, Chris Stewart, Kay Forbes, Liam Doris, and of course Kirsten Smith as well, who have all put in a huge amount of effort. The way this session is organised, there'll be 3 lectures from our distinguished panel, and then there's time for a question and answer and a bit of discussion at the end. And I would really strongly encourage you all, if you do have questions, to note them down. We'll try and get through as many as possible and hopefully get some interesting discussion going. So firstly, it's my great pleasure to introduce to you Mr. Alistair Jenkins. Alistair is a consultant neurosurgeon at the Royal Victoria Infirmary in Newcastle. He has a very interesting and wide experience of neurosurgery, covering all aspects of cranial neurosurgery: tumour, trauma, vascular, pituitary, functional neurosurgery. He's originally from Largs, studied at Glasgow University and did much of his training here before a fellowship in Liverpool, and then taking up a consultant post in Newcastle at the age of 30, I believe, Alistair. Is that right? 31. Okay, nearly there. But certainly younger than most. He is a past president of the Society of British Neurological Surgeons, which is our national body, and he has numerous visiting professorships across the world, and indeed global neurosurgery is a big interest. So I'd like you to join me in welcoming Alistair, please.
Thank you very much indeed, Chris, for that very kind and effusive introduction, and thank you to everyone here for being here, to Digby Brown, I'll try that again with my teeth in, and particularly to Kirsten for organising it. Being at the session this morning makes me realise what a small part of the whole head injury spectrum neurosurgery is. And I just want to share a little bit of what I've done. Now, you may remember the chap from the Atlantic magazine who got accidentally onto the war group chat, and that's exactly how I felt when Chris asked me to do this, because I think, what is my true involvement in head injury? It feels a bit tangential. But then you just think about things, at 20 you worry what people think about you, at 40 you don't worry what people think about you anymore, and at 60 you realise they probably weren't worrying about you anyway, thinking about you anyway. And that can be neatly summarized by this rather important graph, which some of you may be aware of. And that is probably just as well, because this was me back in 1980 when I graduated from this illustrious establishment, Glasgow University, having tried to avoid work as much as I possibly could. And Glasgow, of course, I was familiar with it, but I became more familiar with it. And as you see there, it's a city of extremes, and particularly in the culinary line, extremes from this to what I'm afraid sadly became more familiar to me, to this. And when I came out of university, my career plan, as it had been right since I was about 14, definitely surgery. I wanted to be a surgeon. So I went to the Western Infirmary in Glasgow, and I did my house jobs. Then I did casualty, which is when I first came across head injury. And it was a depressing thing, it really was. Drunk head injuries in Glasgow are not a very entertaining breed. And I got a little bit bothered by the hopelessness of it all. And it seems the Western Infirmary did as well, because that was it a few years later. And so I came out of there thinking definitely surgery still, but definitely not neurosurgery. And then, of course, what happens? I get into a surgical rotation, junior surgical rotation, which boomerangs me straight into the Institute of Neurological Sciences in Glasgow. This is the old institute. And under the beady eye of Professor Graham Teasdale, known to many of you, feared by many of us, also known as Sergeant Pepper. And of course, the second most famous export of Scotland, next to the Tunnock's caramel wafer, is the Glasgow Coma Scale. The Glasgow Coma Scale's importance can't really be overestimated. Before it, there were problems with communication between referring units and central units like the Institute about how a patient actually was. And there were problems in estimating how that patient was progressing hour to hour, day to day, because the language that was used was all different. And it was a bit like this, it was divination. And what the Coma Scale did, and here's Graham teaching a group of the faithful the Coma Scale around the world, what it did was to make this rigorous. It analyzed a whole load of different criteria and brought the eye-opening best verbal response, best motor response. And these were reproducible and reproducible into many, many other languages as well. It also brought me into contact with this chap who was responsible for the most important 2 seconds of my life. This is Rab Hyde, a lovely man, a fantastic neurosurgeon, sadly now no longer with us. And I went up to him at the end of my 6 months. I had gone there thinking I was finally going to be rumbled. I'd blagged my way through university knowing nothing at all, and I thought they'd finally realize this and I'd be out of my ear. But in fact, I really enjoyed it, and they seemed to enjoy me. And I went to Rab and I said, well, look, thank you very much for looking after me. And he was a bit absorbed. He was a bit of a computer boffin. And in those days, a computer was a very rudimentary thing. He was messing around with it. And he said, oh, yeah, that's fine. When could you start? And I thought, what the hell? And I'd never really considered this seriously. So I thought for about 3 seconds, and I gave him a date. And he said, yes, that's fine. Yes, we'll get in touch. And get in touch they did. And so suddenly it was definitely neurosurgery. So they said, go away, get your FRCS. So I got my FRCS, and then I came back into research. It was slightly unusual in those days to do this, but I wanted to get the research out of the way. It was something that was essential to do back then to progress. So I came under the aegis of Jim McCulloch here at the Gaskube Institute, and David Mendelow, who taught me the noble art of rat strangling. And the real brains of the Institute, David Graham, and he analyzed all the samples that we sent from head-injured people and from head-injured rats. So we were looking at head injury, and I think as an introduction to why we were doing it, I don't particularly like Jeremy Clarkson, but I do like this quote from him. It's not the speed that kills you, it's the suddenly stopping that kills you. Because it sets out, it starts out in train a whole cascade of chemical and of physical occurrences that damage the brain. You've got the primary brain injury, focal contusions, hematomas, etc. And that then releases a whole load of secondary injury, and you end up with neurological deficits. And what we were doing was trying to work out ways of protecting the brain, neuroprotection, from these secondary injuries. And there are physical ones, there are ones that look at cerebral blood volume, autoregulation. We were particularly looking at cerebral blood flow. Because I clearly am not going to go into this slide, but this is the sort of thing we're battling against. All these reactions, sometimes with a positive feedback on each other, that end up with cell damage and cell death. And to do this, we had to, I'm afraid, put paid to a few furry friends, and we looked at a number of compounds to try to protect the brain. The problem with this is that you can't knit the brain back together, and we found it was perilously difficult to protect it from further damage. And this is a list of just some of the compounds that we looked at in the early 80s in an attempt to mitigate brain damage. And in fact, none of them worked. And this was really what we felt like. So I then moved out of the lab for the second part of my research time, and I moved into radiology, oddly enough, and into the darkroom. Now, why was that? Well, a few years before, this chap, Godfrey Hounsfield, had invented the CT scanner. The CT scanner was truly revolutionary. I don't know if you know how the CT scanner research and implementation was paid for. The answer was it was paid for by this group of people. because it was known initially as the EMI scanner, EMI. And EMI was the Beatles recording label. And of course, they were making millions upon millions of pounds out of the Beatles. And this is the first clinical picture from a CT. It may not look like much to you, but it was truly revolutionary, because before that, before this three-dimensional view, all we had was these modalities: angiography, nuclear medicine, pneumoencephalography. And particularly angiography and encephalopathy, we're looking at shadows. They were looking at displacement of vessels, displacement of the ventricles, in order to see where there might be a tumor or something. But in head injury, we didn't have much time for that. And so really what we were reduced to was exploration. You had a patient, they had a fixed pupil on one side, so you made a burr hole on that side, see what you could find, drilled another one a bit further forward, turned the patient over, did the same on the other side. If you couldn't find anything, you gave up. But the EMI scanner, it revolutionized all that. And this was what it looked like when I first reached Glasgow. Believe it or not, each slice of the head took 1 minute. And you can imagine trying to hold one of the aforesaid drunk head-injured patients down while you do that. But it gave us very good pictures. And it gave us very good pictures of things like blood clots. This is a subdural hemorrhage, and we'll talk about that shortly. You can see this brain swelling as well as this subdural. But there was a problem. The CT scanner was fantastic at showing things which had a different contrast to the brain: white of blood versus gray of brain. This patient has a diffuse, severe brain injury, is deeply unconscious, and there's, quite frankly, bugger all to see. But meantime, some very clever mathematicians, physicists, had been working on this, the prototype MRI scanner. This is Damadian in the US. And in the UK, where we're very proud that in Aberdeen, John Mallard had almost single-handedly developed a prototype MRI scanner there. And what that was doing was giving us much more anatomical pictures, but more importantly, more information about the actual function of the brain. So Graham Teasdale invested in one of these, and we started doing research. And this is the 80s, you can tell by the haircut, a haircut which clearly was adopted by the researcher at that time, and we started looking at head injury. To do that, we needed another team. This is Dave Wiper. Here, this is Dave and I cycling around Japan, and this is him some years later playing at my wedding. He's a very talented piper, Wiper the Piper. We had Donald Hadley. I don't have a pointer, but he's the chap with the moustache, and Barry Condon, another physicist, and we had a nucleus of people to analyze what we were producing on the MRI. And this was when I had my most important publication. It was an information booklet for the patients, which I drew up using the Bruins as an example family. And the patients we were asking to take part in trials for us. So we had to be nice to them, and this is it. And I even managed a self-portrait at one point. So let's go back to that picture. This is this brain-injured patient. We have no idea what's going on because it's all just gray. What does the MR do? It shows us this. Not only the contusion there that you can see arrowed, but all these little white blobs throughout the brain, reflecting damage to the white matter. Here's another case, pretty normal looking, and this is the same patient with numerous white matter lesions. And what we found was the deeper in the brain these white matter lesions occurred, the more important they were from a prognostic point of view. And I actually put together a computer program to analyze and count these and give prognosis for the patient, which never went anywhere, but it was actually quite accurate. And there were a couple of publications. I hate pictures of papers, but I have to show this, a Lancet publication. A few papers came out of this. And I got my MD, my higher degree, which enabled me to progress in surgery. And I went back to surgery. What was happening over the years after that was that research in head injury was tending to go back to surgery as well. Here's that neuroprotection thing again. How can we neuroprotect physically? And the answer here, as you can see, two things that we could do. We can take out blood clots, and we can decompress the head. It's not sexy surgery. It's not, doesn't make your name as a genius surgeon. And that's why many neurosurgeons are not interested in it. But it can be very, very effective. So these are some surgical trials. The STITCH trial, which was on hematoma, Rescue ICP, which was on diffuse raised intracranial pressure, and Rescue ASDH, which examined whether taking the skull, a piece of skull off, as well as taking out the blood clot, would help. The STITCH trial, I'm pleased to say, was based in Newcastle. There's Newcastle. And what we tried to do there was to assess whether early surgery would improve outcome. And I'm afraid I don't have a pointer, but if you look at the results there on the left, green is a good recovery, which is, I guess, what most of us would want if we had a head injury. And there was zero difference. What it did make a difference to, the top one being the early surgery, the bottom one being the initial conservative treatment, ICT, what did make a difference to was the number of deaths and the number of severely disabled people. So effectively, you were converting dead people into disabled people. And you have to think seriously for the patient and for yourself what you would want under those circumstances. Then moving on to decompressive craniectomy. What's the rationale for that? Well, the brain has got room for three things in it. It's got room for the skull has got room for three things in it. It's got room for brain, it's got room for blood in veins and arteries, and it's got room for cerebrospinal fluid around the brain and in the ventricles. And there's a sort of rule that says after the age of 1 year old, it's a rigid container. It contains these things, and an increase in volume of any of these, so for instance, CSF, that would be hydrocephalus, head injury, you're increasing the size or the volume of the brain. And that has to be compensated by another of them, otherwise the pressure goes up. And so what you have here, numbers 1, 2, 3, and 4, in number 1, you've got the normal situation. Number 2, you've got a frontal hematoma growing there, and a bit of CSF is heading downwards into the spine, a bit of blood staying down towards the heart. 3, it's getting bigger. 4, you have exceeded the ability of the brain to compensate. And you can see the black line, the intracranial pressure is rising. But what if we took off a bit of skull, a very large bit of skull, as you can see here? Would that not let the pressure out and everything would come back to normal? For those who are squeamish, don't look, but this is what it looks like. And you can see the brain is really trying very hard to escape there. And this is what it looks like on a CT scan. You can see the artificial membrane we've put in there to make future surgery easy. And here we've got it done throughout the whole of the front of the head for swelling in the frontal area. The brains behind this was this chap, Hutch, here seen on a trip to Sri Lanka last year, here seen in a more familiar environment for him, clearly. And that's Peter Hutchinson, who's professor of neurosurgery in Cambridge. And he's passionate about this. He's an absolutely superb researcher. And he looked at Rescue ICP, one trial, Rescue ASDH, another trial, with decompressive craniectomy. Rescue ICP, 400 patients, best ITU management versus decompressive craniectomy plus best ITU management. And the paper came out of that. Now, unfortunately, this is the other way around from the previous one. But what you can see here, that in the surgical group, again, the deaths were fewer. But again, you're working towards more disabled people. But then they looked at it at 12 and 24 months. And what they found was that what we mostly consider from a straw poll of thousands of people to be the important thing, the thing you'd want to survive into, actually becomes more and more as time progresses. So you do save more people. You save more people into a reasonably acceptable outcome. But it's very far from being standard practice. It's very far from being something that should be done on everybody. And it really has to be individualized. This patient here, you can see the CT and then the MRI. The MRI is showing diffuse brainstem and medial temporal lobe swelling, and the arrow pointer at a hematoma in the brainstem. That person is not going to have a good recovery, whatever you do with the lid. What about people with a big blood clot? Rescue ASDH, acute subdural hematoma. 450 patients randomized to either craniotomy and hematoma evacuation, or to decompressive craniectomy. That's where you take it out and you put it in the bin or in the fridge, plus hematoma evacuation. And the paper finally came out from that. And what that showed, depressingly, was the craniotomy group on the top and the craniectomy group on the bottom. More deaths, fewer good survivors, but not statistically significant. So the conclusion really there was that disability and quality of life outcomes were pretty similar. So effectively, like so many head injury trials, that was a bust as well. And not only is it a bust, there are significant problems here. Some people in the room may have had a decompressive craniectomy, and this, unfortunately, is what you can end up looking like afterwards. That means you need further surgery to put the lid back on, either a synthetic one or your own one that's been kept in the fridge or whatever. That sounds very straightforward, but actually that can produce problems as well. You get surgical complications there. So for that reason, I guess as time goes on, we have been looking more and more at prevention rather than cure. And everybody here knows that the incidence of severe head injury has gone down since the time that I was dealing with it all those years ago. And that's because of good preventative practices. And, but you know, outside, I took this picture in Lahore. I just like the spelling. And then we went outside the hospital, and here are these two chaps, clearly under the impression that a hairnet will protect them. So that brings me just onto something else. This is a patient arriving at a hospital that I went to visit a couple of years ago. He's an 82-year-old, knocked over by a bicycle, and he was initially unconscious, but getting better. He was taken out of the helicopter. He was taken down to an operating theatre, had a hematoma removed, and I understand he made a very good recovery. And how is this possible? Well, if you turn around 180 degrees from that helicopter, this is what you see. The City of London with all the wealth attached to that. But that really has very, very little impact on this family living on the street in Ethiopia. And boy, there are reasons for worrying about head injury, because the things I was talking about, mitigation by public health measures, even where there are helmet laws, like here, for instance, in Peshawar, in Pakistan, nobody obeys them, and the police aren't interested either. And the risks are quite great. This is a lorry, typically festooned so much that the driver can really barely see, and behaviors like this, and also this, very, very common on the subcontinent, lead to many, many head injuries. And of course, even more tragic accidents like this. If you are scooped up off the road alive or off the railway track alive, this is what you face: a long stay in a totally inadequately funded and inadequate facilities of an A&E department, and operated on in the best operating theatre they can possibly muster, but it's not got the support that we have. Much of the care is given by parents, and the children particularly are greatly at risk, and this sort of outcome is not standard by any stretch of the imagination. The scale of the problem is also enormous. This picture staggered me. This is the map of Africa with various countries superimposed on it. And look at even the United States only fills up West Africa and a bit of the Sahara. Money. NHS budget for 2025 for health, £258 billion, and it's still not enough, as we know. Sudan, almost the same population. The GDP, the whole economy, is a tenth of what we spend on health. So how much are they able to spend on health? So why on earth are we interested in improving or even introducing neurosurgery in countries like that? Aren't there far more important medical problems to deal with? The answer is yes and no, but mostly no. Malaria, AIDS, TB. If you take those and compare them to the unmet surgical need on the blue bar here on the graph, they are completely dwarfed by it. Unmet surgical need is massive, and of the things that are not being dealt with properly, one of the biggest culprits is head injury. So what can we do in our beautiful modern cities? This is actually Riyadh, which has transformed amazingly over the last 20 years. Well, Arthur Ashe, of all people, came up with this maxim: start where you are, use what you have, and do what you can. In other words, don't try to cure all known disease at one swoop, because you won't manage it. So a number of us have got together. Chris is one of them, and we've put together the Society of British Neurological Surgeons Global Neurosurgery Initiative. And what we're trying to do with that is starting small, we find out what's going on already so that we don't duplicate it. We do telemedicine, MDTs, seminars, conferences, training observerships. But particularly what we do is involved in the most important thing in head injury management and in surgery, which is training, training, training. Because if you train people to do proper management of head injury, they will find the resources to do it. So finally, what have I learned in my 45 years of dealing with head injury? Well, primary brain injury can be prevented, but it cannot directly be treated. Aggressive therapy for reduction of secondary injury, so intracranial pressure monitoring, deep sedation, etc., can be very rewarding, but you should not try to preserve life at all costs, because if you talk to some very disabled survivors, many of them are not happy. In almost no other area is teamwork so important, and it's amazing to see what a fantastically large team we have here interested in this subject. But most of all, for me, I was very lucky to start this journey here in Glasgow, and I'm very grateful for having done that. I'm very grateful to the organizers and for Chris for asking me to talk. Thank you very much.
Thanks very much, Alistair, an engaging and humorous talk as always.